Okay, ready?
Okay. The floor is
Okay.
all yours, sir.
Thank you so much. Sorry for some delay, but
No worries,
not
sir.
e-
No worries.
not always easy. Okay, we are now speaking about older women with breast cancer, and the question is sometimes, of for some of these patients, we can break the radiation therapy standard that we well know. General situation about radiation therapy and elderly is a growing demand, and this is due to the increase in life expectancy. We have worldwide in 5 years ago, 8.5% of the population with at least or more 65 years old. In the next years, 30 years, a long time, this percentage will double. And mainly in Europe, but not only in Europe. And this we have to face for the future this problem. What happens usually in a clinical setting about the management of elderly patients? We have some data, for example, a survey from RTC European study indicate that only 22% of the enrolled patients were 65 years old or older. This percentage drops to 8% in those patients over 70, sorry. And this means that when we have the result of a trial, this includes only a small percentage, probably not significant percentage, and really we don't have evidence about the effect on this elderly population. What we know also in the US database, huge number of patients with more than 70 years, and application of indication for radiation therapy after breast conserving surgery was recommended in less than 70% of the patient totally, but with important difference according to the different age group. 80% in relatively younger patients, or not so old, 70 to 74, decrease to 75% between 75 and 79, and increase about 50% in patients with 80 years old or more. The same happened in Europe in cancer, according to the Cancer Registry of Switzerland. Radiation therapy after breast conserving surgery declined from 93% in the age between 65 to 70, 32% in 80 years old or more. The same trend for post-mastectomy irradiation. This is the standard according to NCCN net rules, and we know very well radiation therapy after breast conserving surgery on the whole breast with or without the boost. Target is the breast tissue, the whole breast tissue, this conventional dose or hypofractionated dose. And the last version, hypofractionation, is recommended for most of the patients. Tumor bed is also recommended in patients at high risk. We have some alternative to this standard in elderly patients. Alternative may be to use systematically no boost independently from the risk category of the tumor, to use hypofractionation, not only 3 weeks, but a strong hypofractionation that means, as tested more recently in UK and in other countries, 5 fraction only. We can use an extension of partial breast irradiation for indication. And of course, we have also to discuss in selected patients the total omission of radiation therapy. This is very well-known study by RTC, published by Harry Barteling 5 years ago, with a long-term follow-up, 20 years of follow-up, and in which the conclusion was that there is an advantage in the boost dose, but at different level by age. The extra dose can be avoided in most patients older than 60 years. So we can consider this a strong recommendation. We know that hypofractionation can be applied more extensively than the past because it's safe in terms of local control, in terms of overall survival, and also in terms of toxicity. And we can use also in elderly, systematically in elderly patients, because of course it's really important to reduce the overall time and the number of access of this patient to the hospital. We have also other schedule, like in the import law trial indicates it, in which we can see it also to reduce the dose or to use partial breast irradiation only, seems to be in low-risk patient equivalent to use the whole breast, the standard whole breast irradiation, also equivalent in terms of adverse effect. Omission of radiation therapy after breast conserving surgery is a risk. Is a risk because the trials published in the past year confirmed that we have to accept, the patient has to accept a higher rate of local recurrence, in spite of no evidence of detrimental effect on overall survival. But we know that we have from 3 to 4 up to 6 times more risk for local recurrence. What we have to consider if in our patient, in our old patient, we want to break the standard. First of all, we have to consider the histopathological factors, but above all, the molecular profile of the disease represent the best indicator for a risk stratification independently from the age, but at the best we can use for aged patients. Age, if associated to general status and eventually comorbidities, however, remain an important element to consider. But the real point, the discussion, is represented by the individual risk threshold value for each patient. So the patient availability, the patient compliance about the perception of the risk. If the patient can accept a low, very low risk or higher risk. In terms of absolute number is not so much, but in terms of percentage may be important. And in any case, this point have to be discussed deeply with each patient. What is also important is a comprehensive geriatric assessment, because we know that about half of the patients with 65 years old have 1, 2, or 3 or more chronic disease. The incidence of hypertension is about 1/3, respiratory disease more than 10%, diabetes, angina, and coronary artery disease 10%. So this sort of different problem, including also to an evaluation about the cognitive status of the patient. The score for assessing the screening to assess the performance of the patient is very important, because we know in a recent paper published, in which if we apply some test evaluation, for example, very simple test, this geriatric 8, this is a short screening tool to identify patients who are frail. And you can see that there is a statistical difference in terms of survival between patients that are fit and patients that are unfit, so means frail. The same applying other type of test, for example, the timed get up and go test, is a physical performance test to quantify mobility as a measure of rate. And again, we have a difference, statistical difference, very important in terms of overall survival between the frail patient and no frail patient. This is also true with less limited impact on survival for breast. This is for all the tumor. This is for breast. We have also other prognostic factor. For example, patient if take medication for other disease, yes or no. If we have to apply combined drugs, chemotherapy, and of course, also the patient suffer of or is suffering from acute severe toxicity. Can be safe to leave the standard? Not always. Again, a very recent paper on the Green Journal in which we can say we can see the recurrence-free survival according to different approach. That means lower survival in case of surgery alone, better survival applying radiation therapy or the combination between surgery, radiation therapy, and endocrine therapy. Endocrine therapy alone is worse with respect to the use of adjuvant radiation therapy. And this with less significant value also in terms of breast cancer specific survival and overall survival. You can see here a very great difference using or not using radiation therapy. Also, the adherence to the program of endocrine therapy is different for patients because we observe that after 2 years, a significant percentage of the patient go out of the program and discontinue the use of endocrine therapy that usually is prescribed up to 5 years after the surgery, after the diagnosis of tumor. IRT may be also an option in older patients. We have just updated our results that are in press on Lancet Oncology. Really a long process of revision, at least 5, but at the end has been accepted. This confirmed what we observed in the first paper several years ago, a statistical difference between intraoperative irradiation by electrons and the standard treatment by whole breast irradiation, with no difference in terms of overall survival, even at very long time, 15 years of follow-up. So that means that we have a very similar situation with respect to the total omission of radiation therapy, and we have to discuss on the patient what is the threshold of risk of each individual patient. Quite interesting is also the position or the perception of the patient is also has been recently published. Treatment option for older women, 30 participant women with an average of 72 years old, and is interesting to see that women expressed the belief that age-based guidelines were appropriate on the basis of the decreased recurrent risk and increased fright in older patients. However, most of the participants stated that these guidelines should not apply to healthy older women with a long life expectancy. So they ask for the better standard of care. Some participants struggle to understand that the basis for treatment escalation is in older patients is a favorable, not poor prognosis. Women who said that they would undergo sentinel node biopsy, 40%, perceived the procedure as low risk and provided peace of mind. Most participants 73%, unfortunately for our discipline, expressed the preference for omitting post-lumpectomy radiotherapy because of the perceived risk, lack of benefit, and inconvenience. For these reasons, it is important really to shorten the treatment time. The best way in order to omit radiation therapy to follow biology of the tumor. This is a long list of ongoing trial based on different selection tests from Oncotype, Prosigna, etc., or using biological parameters. So, of course, we have as a point at long term, 5 years, and we are waiting for the result of this study that has not been published in a peer review paper, but has been some of them presented in the meeting. These are the standard after mastectomy, is well known, and can shift this. What we have to consider if you break the standard, we have to consider in order to avoid for this elderly patient an increased risk of toxicity due to radiation-induced damage to the heart and lung, and for lymphedema. We need to have all the technical solutions that are available, and we have to put them into action in order to minimize this type of risks. And of course, we have to wait evaluation, the ongoing clinical trial, the previous one, and in the next slide about the local regional irradiation that is positive would allow to reduce dose and volume of radiation therapy or to omit it. We know very well the problem of cardiotoxicity. We have an increase per gray is 7% more per gray given to the whole heart, etc. And quite recently, we have some dose constraint that is very important to follow, both to the left ventricle and also in this small artery, the left anterior descending artery. This is an interesting work made by the DEGRO. DEGRO is the German Society of Radiation Oncology. You can see here the target that is very close to the internal part of the chest wall. And we have in our treatment plan also to indicate this point of the left circumflex artery and the left anterior descending artery. That's a very critical point and can be a negative effect on the risk of heart disease. Anyway, with modern technique of radiation therapy, the relative risk of negative cardiovascular event is decreased along the year. It is really important because we can use different technique, different tools in order to reduce the dose to the heart, mainly the deep inspiration breath hold, but also, of course, respiratory gating. In some cases, for example, large breast prone position, extension of partial breast irradiation indication, and maybe also in the future, proton therapy. You can see an example of using the deep inspiration breath hold technique is able to reduce 3 or 4 times the mean and the maximum dose to the whole heart, to the left ventricle, and again to the left anterior descending artery. Even, of course, relevant areas of heart can be exposed to the medium high dose. We don't know exactly long-term effect of EMRT in breast cancer, what means this dose, low dose, intermediate dose, but is a larger volume with respect to the classic approach with the tangential beam. Lymphedema is also important, especially for adverse influence of patient quality of life, performing skill at home, at work, functional impairment, psychological distress, etc. Primary treatment factor of course, the type and the extent of axillary dissection and regional node irradiation. It is important to follow the patient at risk, and one of the most accredited system is the use of perometry. We have also other systems to prevent lymphedema. One is to spare the lateral board of the supraclavicular field. You can see a comparison between different treatment plans, standard, modified, EMRT, and proton therapy, or already mentioned the arm node, that is to identify the drainage from the arm with respect to the drainage from the breast. That is important that if we identify using PET or CT PET and to try to spare this drainage node. With respect to ongoing study, we have two very interesting studies. They are addressing the role of regional nodal irradiation and surgical approach to axilla, the POSNOC and the BOG, and investigate whether omitting any type of adjuvant axillary treatment is not inferior to surgery or irradiation. In this case, up to T2 tumor, accepted patient with 1 to 2 macrometastasis, and accepted breast conserving surgery or mastectomy. Small difference in the other study, again, is a non-inferiority study. The patient, same stage of patient, but in this case has been accepted up to 3 positive nodes, micro and macro metastasis, only patient operated by mastectomy. Another option for the future is to consider to reverse the sequence, and with moving radiation therapy from the post-operative setting to the pre-operative setting. Maybe a list of possible advantage, especially in case we receive also neoadjuvant treatment by drugs, etc. And what is of interest is this, the POPART study is just a feasibility study published quite recently on BMC, 2020, in patients with non-metastatic, age of more than 18, good performance status, and eligible for neoadjuvant chemotherapy. What is interesting is the extreme fractionation applied for this patient in preoperative setting, and the trial provides 5 fraction of 5.7 gray to the whole breast with a simultaneous integrated boost to the tumor bed, if post-operative setting, in this case from 5 per 6.2 gray. And also the same hypofractionation, extreme hypofractionation, is applied for regional node irradiation, 27 gray in 5 fraction of 5.4 gray each. This is really a new approach in terms of fractionation with respect to the timing of surgery, but also with respect to the more traditional concept in fractionation, especially for the supraclavicular and axillary region. Just to conclude, summarizing some points that I tried to discuss. First is the incidence of breast cancer increase with age, at about 25-30% of the breast cancer happen in women more than 70 years. So these are really also a social problem. General health status of this type of patient can be rated by geriatric assessment, which allow several things: estimation of life expectancy, predict treatment toxicity, detect multiple health problems, and allows direct geriatric intervention and personalized treatment adaptation. That is the really important concept. In general, older breast cancer patients are less likely to be treated according to accepted treatment guidelines. This happens in spite of different recommendations, but this is the reality of the daily clinical practice. And under treatment can have a strong negative effect on survival. Adjuvant